Welcome to the funnel effect. Today, we're diving deep, really deep, into a demanding procedure in interventional cardiology. We're talking about the double kissing crush technique, usually called DK crush. Our analysis is based on a fantastic, very detailed troubleshooting guide. It's authored by Allison B. Hall, Ivan Chavez, Santiago Garcia, and several other collaborators. It was published in Eurointervention back in 2021.
That's right. And our mission today is really about procedural mastery. DK crush, well, it's the most studied two-stent strategy out there for these really complex coronary bifurcation lesions. The thing is, while the clinical data, the outcomes, they look great long-term,
Yeah.
it's notoriously complex to perform. You often hear that phrase, no pain, no gain.
Exactly. And that pain, that difficulty is what we want to help you, the listener, minimize today. Because let's be clear, provisional stenting, just one stent in the main vessel, that's usually the go-to for most bifurcations. But
Yeah.
sometimes you face a lesion with a really large, really diseased side branch, the SB, and in those cases, you have to use two stents. The evidence really points towards DK crush for those situations.
Yeah, absolutely. And maybe we should quickly define what we mean by a bifurcation lesion just to set the stage. It's essentially where a main coronary artery, the main vessel or MV, splits into two branches. The trouble starts when there's significant disease right at that junction. We often use the Medina classification to describe how complex it is. For instance, a Medina 10111 lesion. That means you've got disease just before the split, disease in the side branch opening or ostium, and disease in the main vessel right after the split. When you see a level 101 on the angiogram, you know you're settling in for a challenging case.
Definitely sounds complex. So before we jump into the 12 steps, let's nail down some key terms we'll be throwing around. PCI, that's percutaneous coronary intervention, the overall procedure. MV is main vessel. SB is side branch. POT means proximal optimization technique, super important for reshaping the stent later. LM refers to the left main coronary artery. That's the big one, the highest risk area. And we'll mention imaging a lot, specifically IVUS, which is intravascular ultrasound, and OCT, optical coherence tomography.
Good call. Got to have the lingo down. Okay, so the big question first, why? Why go through all this complexity? Why the pain? The answer, plain and simple, is in the clinical trial data, specifically the DKCR-US adhesive trials. They really establish why this technique, despite its difficulties, is often the best choice.
Yeah, the data in the paper's supplementary tables, it's pretty stark, isn't it? When you look at the actual numbers, the reduction in problems for patients is significant.
It really is. Let's break it down a bit. First, comparing it to older techniques. DKCR-USH, look at DK crush versus the classic crush technique. For true bifurcations, DK crush was clearly better. We're talking about major adverse cardiac events, or MBE, things like death, heart attack, needing another procedure. The MATE rate for DK crush was 11.4%. For classic crush, it was way up at 24.4%.
Wow. 24%. That's almost 1 in 4 patients having a major issue or needing to come back. So yeah, getting that down to 11% is a huge win. Makes the difficulty seem worthwhile.
It does, and that advantage holds up even when you compare it to provisional stenting, which is, as you said, the usual first choice. DKCR-USH2 showed DK crush was superior for true bifurcations. Then DKCR-USHV focused specifically on the left main, the LM bifurcation. That's the highest stakes area. There, target lesion failure TLF was 5.0% for DK crush. For provisional, it was more than double, at 10.7%.
Okay, protecting the left main like that, that's incredibly valuable. But it begs the question, if it's that much better, particularly for complex cases, why isn't it the default? Why stick with provisional so often? Is it purely the complexity and time involved?
That's a really good point. It boils down to risk-benefit for the specific lesion. Provisional stenting is quicker, uses less gear, less radiation, and has fewer steps where things can go seriously wrong. So for simpler bifurcations, it's often the safer, more efficient approach. But when you're facing that complex, true bifurcation, like a Medina 10101, especially with a large, important SB, the long-term results, keeping that side branch open and well stented, often demands the kind of coverage that DK crush provides.
And that superior coverage, that structural integrity, that links back to how DK crush works, doesn't it? Something about the final steps.
Precisely. A big meta-analysis pointed this out. DK crush seems to work better, partly because you're much more likely to successfully perform the final kissing balloon inflation. The success rate for that final kiss is around 99% with DK crush. With other two-stent techniques, it's often lower, maybe 80–85%. Getting that final inflation done properly means the stent layers cover the side branch opening optimally. It minimizes the risk of the branch closing down later, and it avoids creating a dangerous gap, sometimes called a neocarina, near the split.
Okay, so the meticulous step-by-step process is designed to ensure that final optimal expansion and coverage. The complexity serves a very specific evidence-based purpose for these tough lesions. Gain justifies the pain.
Couldn't have said it better. All right, let's get into the steps. Step 1, angiographic assessment and wiring. This is foundational.
And the guide emphasizes you can't just rely on the basic X-ray picture, right? You need more detail.
Absolutely critical. Intracoronary imaging, IVUS or OCT, is essentially mandatory here. It's not just for a look-see. You need quantitative measurements. You have to know the precise diameters of the main vessel and the side branch to choose the right stent sizes. You need to see how much calcium is there, where it is, because that predicts how hard delivery will be, and you need to measure the angle of the bifurcation. Without those accurate numbers, you're basically guessing on stent size, and that's a recipe for failure down the road. Once you have that info, the action is straightforward. Wire both the MV and the SB. Secure your access.
Okay, step 2, guide selection and preparation. This sounds like getting the right tools and making sure the path is clear. The source mentions maybe needing bigger guides, 7 or 8 French, often via the leg, the femoral artery, not the wrist. Why?
It's all about support and friction. Imagine trying to push two relatively stiff things, like a stent and a balloon, side by side through a tight, maybe calcified bend in the artery. You need a guide catheter that gives you maximum backup support. Larger guides, like 7 or 8 French, provide a wider internal highway, reducing friction between devices. And crucially, their larger size and often stiffer construction mean they anchor better at the entrance of the coronary artery, giving you a solid platform to push from. Femoral access often facilitates using these larger, more supportive guides.
And the specific type of guide matters too. You mentioned some names earlier.
Yes, we tend to prefer guides that give what we call active support. Things like the extra backup guides XB or EBU for the left system, or an Amplatz left and AL guide for the right coronary artery. Unlike passive guides that just sit there, these actively engage the wall of the aorta or the coronary ostium, the opening. They give you much more stability when you're trying to advance equipment against resistance, which you definitely will be doing in a complex DK crush case.
Makes sense. And then lesion preparation. Pre-dilating with balloons. This isn't optional, is it?
Definitely not optional. Mandatory. If you don't prepare the lesion properly with balloon angioplasty first, you'll likely struggle to deliver the stents later. It wastes time, increases radiation, increases risk. If there's heavy calcium, simple ballooning might not be enough. You might need to consider plaque modification up front, like rotational or orbital atherectomy, basically drilling or sanding the calcium to make sure subsequent devices can pass and, importantly, fully expand.
All right, foundation laid. Now, step 3. This feels like the first major hurdle. Stenting the side branch, SB, with just a short bit protruding into the main vessel, MV. The big problem here is often just getting that first stent to the side branch.
Yep. Exactly. Failure to deliver the SB stent is common if preparation wasn't adequate or if the vessel's really twisted, really tortuous. So if the stent gets stuck, what do? You have a sort of stepwise approach. First, maybe try more aggressive balloon dilation. If that doesn't work, you reach for the most deliverable gear you have. That means ultra-low profile balloons, things like a 1.0 millimeter Sapphire Pro or a 1.5 millimeter Takeru. These are designed to slip through tight spots.
But what if even those tiny balloons won't make it? How do you get more pushing power without damaging the vessel?
Good question. That's when you need to enhance your support. Several tricks here. You could try using a microcatheter, an MC, first. It's like a tiny flexible tube that can sometimes smooth the path or help direct the wire better. If you still need more muscle, you might switch to a more supportive guide wire, like a wiggle wire, which has more shaft strength. Or you bring in the heavy artillery for support. A guide catheter extension, like a guide liner or a guidezilla. And then there's the really advanced technique, the side branch anchor technique. You basically inflate a small balloon distally in the side branch itself. This anchors the guide catheter firmly, giving you a super stable platform to push the SB stent across a difficult lesion in the ostium.
You mentioned atherectomy for prep. If the stent just won't go, do you consider drilling then?
You think about it very carefully. If it's a large side branch, heavily calcified, maybe in the left main, and the angle isn't too sharp, then yes, atherectomy might be necessary up front or even as a bailout. But you generally want to avoid drilling in small branches or ones that take off at a very sharp angle. The risk of causing a tear or perforation is just too high. So usually it's balloons first, then support techniques, and atherectomy is reserved for specific, challenging situations.
Okay, let's say you get the stent delivered. Now the precision part. How much should it stick out into the main vessel? The source is quite specific on this.
Yes. The target is a short protrusion, 2 to 3 millimeters into the MV. It's a real balancing act. Too short, say just 1 millimeter, and you risk completely missing the true ostium of the side branch when you deploy. That's a disaster. Too long, and you have excessive metal in the main vessel, which isn't ideal either. So if you have to choose, it's generally better to err slightly on the side of a bit longer, maybe 3-4 millimeter, rather than risk being too short and missing the target. There's a technique mentioned, the independent hand technique, that helps with this. You basically use one hand to gently pull back slightly on the guide catheter, countering the forward push, while your other hand makes tiny controlled advances of the stent delivery system. It allows for very precise placement.
And one last crucial point for step 3, which actually sets up step 4, positioning the crushing balloon.
Critically important foresight needed here. The balloon you're going to use to crush the SB stent against the MV wall. That balloon needs to be positioned in the main vessel before you deploy the side branch stent. If you deploy the SB stent first, its metal struts protruding into the MV can make it incredibly difficult, maybe impossible, to then advance the crushing balloon past it. So park the crushing balloon first, then deploy the SB stent. Ideally, this crushing balloon is sized appropriately for the main vessel, maybe even slightly oversized relative to the distal MV reference, to ensure you get a really good crush.
Okay, SB stent deployed. Crushing balloon ready. Step 4, balloon crushing of the SB stent. Inflate the balloon in the MV, crush the SB stent struts. But wait, check first.
Yes, absolutely. Before you crush, take a good angiogram, maybe even use IVU SOCT again if you're unsure. You must confirm the SB stent is fully expanded and looks good. Check for any dissections or problems at the edges of the SB stent. Once you crush it, accessing the SB again becomes much, much harder. You don't want to trap a poorly deployed or problematic stent under another layer of metal.
Right. Now, the big debate, the jailed wire, the wire that's still down the side branch. Do you leave it in place while you crush?
This is a key technical point in DK crush. And the consensus, supported by the source material, is generally, yes, it's acceptable and often helpful to leave the SB wire jailed during the crush. Why? Because that jailed wire keeps the SB path open, it can maintain some flow, and critically, it acts as a marker, making it easier to rewire the side branch later. This is especially true if the SB takes off at a difficult angle. But, big caveat, you jail the wire, not other equipment. Never jail a balloon or a microcatheter.
But isn't there a risk of damaging or even breaking that jailed wire when you inflate the crushing balloon at high pressure?
There absolutely is a risk, and wire choice is paramount here. The studies cited in the source looked at this closely, and the findings are clear. Polymer-jacketed guide wires, those with a smooth plastic coating, seem to tolerate jailing very well. Damage was seen in only like 2 out of 115 cases in one study, and it was mild. Compare that to non-polymer jacketed wires, the standard metal ones. They showed damage in 55% of cases, including internal fractures, meaning the core of the wire broke. So the bottom line is, if you're going to jail a wire during the crush, it really should be a polymer jacketed wire.
Okay, polymer jacketed wire it is. But what if, even with the right wire, it gets stuck? You can't pull it out after the crush. That sounds like a nightmare scenario.
It is a potential nightmare. And the absolute #1 rule is, do not yank forcefully on a trapped wire. You risk breaking it, leaving a fragment behind. That often means calling the surgeons for emergency retrieval. The recommended rescue maneuver, counterintuitive as it sounds, is to try and advance something over the trapped wire. Usually a small balloon or a microcatheter. The idea is to gently nudge the crushed stent struts away from the trapped wire tip, freeing it up enough so you can then withdraw it carefully.
Pushing something into that crushed segment sounds risky too, though. Like you could cause more damage. How often does that work without problems?
It's definitely a high-risk maneuver, no question. You have to be incredibly careful. You're advancing a smooth, low-profile device, applying controlled force just where needed, hopefully. It's generally considered safer than pulling, which puts uncontrolled tension on the wire itself. It works most of the time, but requires skill, patience, and often imaging guidance like IVUS to see what's happening. It's not something you undertake lightly.
And assuming you get the wire out, there's still one more potential danger related to the guide catheter, especially in the left main.
Yes, a very important safety step. When you finally pull that jailed wire out, the tension release can cause the guide catheter tip to jump forward deeper into the coronary artery. If that happens, it can damage the newly deployed stent, cause longitudinal deformation, basically squashing it, or even dissect the ostium, the opening of the artery. Catastrophic complications. So, the rule is, Before you withdraw the jailed SB wire, you must pull the guide catheter back, partially or almost completely disengaging it from the coronary ostium. This prevents that dangerous forward jump. Protect the work you've done.
Got it. Safety first. Okay, wire out, SB stent crushed. Now, step 5. Rewiring the side blanch through that crushed stent layer. This sounds technically demanding.
It is. And this is where DK crush really differs from, say, classic crush and why it's generally superior. The rule here is you must aim to recross through a proximal stent strut. You want your wire to enter the SB closer to the main vessel origin, not further down through a distal strut opening. Why? Recrossing distally tends to badly deform the crushed SB stent and can leave a significant gap near the carina, that neocarina issue we mentioned. Proximal recrossing minimizes deformation and sets you up for better coverage during the next step.
But finding and penetrating that specific proximal strut through a layer of crushed metal, especially if the angle is sharp, it must be tough. What's the plan if the wire just won't go?
There's a systematic algorithm, often shown visually, like in Figure 3 of the source. First, you try different wires. If your standard workhorse wire fails, switch to something else, maybe a hydrophilic wire for slipperiness, or keep using a polymer jacketed one. Sometimes even a stiffer CTO wire might be needed just to puncture through. And critically, you change the shape of the wire tip. You might need a very short, acute angle bend, or maybe 2 bends, or sometimes a broader, gentler curve works better. You have to experiment to find what engages that proximal cell.
The source mentions some pretty specific advanced techniques too, like the hairpin technique. How does that work?
Ah yes, the hairpin wire technique. It's quite clever, especially for side branches that come off at almost 90 degrees or even sharper angles. You put a really big, exaggerated loop or bend near the tip of the wire. You then advance this whole loop past the side branch opening, down into the main vessel. Then as you gently pull the wire back, that big loop caches on the carina, the divider, and sort of springs or pops the wire tip sideways into the side branch ostium. It uses the vessel's own geometry to help you make the turn when direct steering fails.
And microcatheters play a role here again, not just for support, but for steering.
Definitely. A standard microcatheter can help you shape the wire tip quickly right near the target. But for really tough angles, you might need specialized steerable microcatheters. Things like the Venture or Swift NINJA have deflectable tips, so you can literally point the catheter, and thus the wire, towards that proximal strut you need to cross. Another very useful tool is a dual lumen microcatheter, like the twin Passy torque. You advance this device over the main vessel wire, then you use it second over the wire lumen to direct the side branch wire very precisely towards the target cell. It gives you excellent directional control.
Okay, let's assume you've successfully rewired the SB proximally. Step 6. The first kissing balloon inflation, KBI. 2 balloons, one in MV, one in SB, inflated together. Sizing must be key here.
Sizing is absolutely critical, and again, imaging like IVUS or OCT is your best friend for getting it right. For the balloons themselves, you size them according to the reference diameters of the distal MV and the SB. But for understanding the proximal main vessel segment, where both balloons will be inflated side by side, we often refer to Finette's law. It's a geometric principle. It states that the ideal diameter of the vessel just proximal to the bifurcation should be about 2/3 of the sum of the diameters of the 2 daughter branches. So, proximal MV diameter should ideally accommodate 0.67 times diameter SB plus diameter distal MV.
So if my SB is, say, 3.0 millimeters and the distal MV is 3.5 millimeters, sum is 6.5 millimeter. 2/3 of that is around 4.35 millimeters. So the proximal MV needs to accommodate that size for an optimal kiss. What if the actual vessel isn't that big?
That's exactly the challenge. Finette's law gives you the theoretical ideal for flow dynamics. If the proximal vessel is healthy and compliant, it might stretch to accommodate. If it's diseased or calcified, it won't. You might have to accept a slightly suboptimal kiss geometry, or perhaps do more aggressive preparation of the proximal segment if needed. When choosing balloons for the kiss, we generally prefer non-compliant ones. They inflate more evenly and exert predictable pressure, helping to fully expand the stent struts against the vessel wall.
And the inflation sequence itself, just blow them both up together.
The recommended approach is actually the 2-step kiss. First, you do individual high-pressure inflations in each branch separately, MV balloon, then SB balloon, often at 20 atmospheres or even higher. This really sets the stents firmly against the walls. Then you do the simultaneous kissing inflation, but usually at a lower pressure, maybe 12 to 14 atmospheres. The main goal of the simultaneous part is to ensure the carina, the divider, is nicely shaped, and the SB ostium is optimally opened and covered. All right, first kiss done. Now we move to step 7, stenting the main vessel, MV, across the side branch.
Okay, quick check. What about that side branch wire we just used for the kiss? Does it stay in?
Good question. Typically, no. You usually remove the SB wire before deploying the MV stent. The reason is you don't want to sandwich it between the new MV stent and the already crushed SB stent layer. That risks trapping the wire, leading to all the retrieval problems we discussed earlier. So SB wire comes out. Then you position the MV stent. Critically, this MV stent needs to be long enough. It has to completely cover the entire segment where the SB stent was crushed and extend proximally far enough to allow for the next crucial step, POT. That generally means extending at least 6 to 8 millimeters proximal to the carina.
And if this big MV stent now gets stuck, maybe catching on the crushed SB stent metal.
If the MV stent won't advance smoothly, it usually means the path isn't clear enough. The standard fix is to go back in with a balloon appropriately sized for the MV and perform further dilation to ensure the stent delivery system can pass without issues.
Okay, MV stent delivered. Step 8. The proximal optimization technique, POT. You've mentioned this is vital. Why exactly is POT so important in DK crush?
POT is absolutely indispensable here for a couple of key reasons. First, remember that MV stent you just placed was sized based on the diameter of the distal main vessel. The proximal part of the MV is almost always larger, so the proximal part of that new stent is underexpanded. POT uses a balloon size 1.1 to the proximal MV reference diameter to fully expand that segment, ensuring it sits perfectly against the vessel wall and has a nice circular shape. Second, and this is crucial for the next steps, POT fundamentally reshapes the stent struts right at the bifurcation. It flares them outwards. This does two things. It makes it much harder for the wire to accidentally go behind the MV stent struts when you rewire the SB again later, which is a disaster. And it maximally opens up the window or cell of the MV stent that's sitting over the SB ostium, improving access.
And getting the POT balloon position just right sounds critical for that first POT.
It's totally critical. For this first POT, the distal marker of the POT balloon needs to be positioned precisely at the carina, right at the flow divider where the vessel splits. Too distal, and you risk distorting or crushing the SB ostium area. Too proximal, and you don't achieve that crucial flaring of the struts covering the SB opening. Right at the carina is the target.
Okay, we've built the main structure. EBI stent crushed, MV stent deployed over it, first POT done. Now we enter the final optimization cycle. Step 9. Second rewiring of the SB. Back through both stent layers now.
Yes, this can often be the toughest rewiring challenge. The wire now needs to navigate through the original crushed SB stent layer and the overlying MV stent layer. The strategy is the same as step 5, following that troubleshooting algorithm, figure 3. You'll likely need those polymer-jacketed wires again. Maybe the hairpin technique at the angle is severe, and microcatheters, especially dual-lumen ones, can be lifesavers here for directional control.
Assuming success with the rewire and getting balloons down both branches again. Step 10. The second kissing balloon inflation. Final KBI.
This is the final sculpting, the definitive optimization of the bifurcation geometry. If you struggle to get a balloon down the SB at this stage, it's back to the usual tricks. Low-profile balloons, more supportive wires, guide extensions if needed, but there's a very important restriction here. Atherectomy is absolutely contraindicated at this stage. You cannot use rotational or orbital atherectomy once both stent layers are fully deployed. The risk of catastrophic stent damage or vessel injury is far too high. This really underscores why thorough lesion prep way back at the beginning is so important.
Makes sense. No drilling through freshly placed metal. Okay, final kiss done. Then step 11. Repeat POT. Re-PO2. Why optimize the proximal MV again?
Good question. It might seem redundant, but the final KBI, with two balloons inflating side by side, can sometimes slightly distort the proximal MV stent segment again, maybe causing a bit of ovality or minor strut malapposition against the vessel wall. Re-POT, using that same proximal MV-sized balloon, just provides that final touch-up. It ensures the proximal MV stent is perfectly circular, fully opposed to the wall, and it can further help optimize the angle and opening towards the SB ostium.
Is the balloon positioning for re-POT exactly the same as the first POT?
There's a subtle but important difference often recommended. For the first POT, we aimed the distal marker right at the carina. For this re-POT, it might be better to keep the distal marker just proximal to the carina. The thinking is, you've already perfectly sculpted the bifurcation itself with the final KBI. You don't want to potentially disturb that delicate architecture right at the carina. The goal of re-POT is mainly to ensure the proximal segment is perfect, so keeping the balloon just slightly back achieves that without re-stressing the absolute bifurcation point.
Okay, final touch-up complete. Step 12. Reviewing the final result. Time to admire your work and make sure everything's okay.
Exactly. And this isn't just a quick look with angiography. Mandatory final intracoronary imaging, IVUS or OCT, is needed. You have to measure the result. Did you achieve adequate stent expansion? Is the minimum stent area, MSA, acceptable, especially in the left main where benchmarks are often set? For your example, 5.0 millimeter in distal MV, 8.0 millimeter in proximal LM. Is the SB ostium well covered and well expanded? Imaging gives you the definitive answers. You're confirming you achieved the geometry predicted by Finette's law and that there's no significant residual narrowing or malapposition.
And given all the tricky wiring we've talked about, pushing wires through crushed metal multiple times, any specific safety checks related to that?
Absolutely critical final check. Besides looking for obvious things like dissections at the stent edges, proximal or distal, you must pay extremely close attention to the very distal tips of where your guide wires were. Because of the force sometimes needed and the multiple rewiring attempts, there's a real, albeit small, risk of distal wire perforation, the wire poking out of the vessel far downstream. It can be subtle on angiography. You have to specifically look for any tiny puff of contrast leaking out distally. Missing a perforation can lead to cardiac tamponade, a life-threatening emergency. So vigilance is key in that final review.
Wow. Okay, that was an incredibly detailed journey through 12 complex steps. It really underscores that DK Crush isn't for the faint of heart. It's definitely a no pain, no gain scenario.
It truly is. And I think the main takeaway for you, the listener, isn't just memorizing the 12 steps. It's about understanding the troubleshooting mindset required. The real skill lies in recognizing immediately when something isn't working, stent won't cross, wire won't recross, balloon won't deliver, and knowing which specific tool or technique to grab next. The anchor balloon, the hairpin wire, the specialized microcatheters. Mastering these is what reduces the pain and ensures you achieve that well-documented clinical gain.
And that clinical gain, those superior long-term outcomes for these very complex patients, is ultimately why interventionalists invest the time and effort to master this demanding technique.
Precisely. Which leads to a final thought, maybe something for you to ponder. We spent a lot of time talking about the mechanics, crushing metal, high-pressure inflations, forcing wires through stents. Considering DK Crush relies so heavily on these aggressive mechanical steps, these multiple layers of crushed and reformed metal, what are the very long-term implications for the structural integrity of those stent layers? Years, even decades down the line, how does that manipulated metal hold up inside the dynamic environment of a beating heart artery? That's a question we're still learning about.
A fascinating and slightly sobering thought to end on. The long-term consequences of our interventions. Thank you for watching The Funnel Effect.